Okay, so we've already started to talk about Prethemin, and I'm now coming to my second favorite subject, and that's the PMS. Because there are so many women that suffer from PMS and they think it's just normal to have it, and they have the impression nothing can help them, and they almost have given up. Okay, so I would like to start again with 3 patients, and you can think about what you would do with those women. Number 1, she's a 25-year-old woman suffering from premenstrual syndrome, especially mood swings, bloating, and mastalgia. Second one, a 34-year-old woman suffering from a PMD variant, an exacerbation of psychosis during the luteal phase. She's treated with lithium by her psychiatrist and does not want to take hormones. So that's a real patient, this one, the second one. Third one, also very common. A 44-year-old woman complaining of increasing PMS symptoms such as depression, sleep disorder, and fluid retention. Cycle has changed slightly. She's now in the early menopausal transition. Okay, now you can start thinking about what you could do, and we start to talk about PMS. Okay, so a lot of women are affected by PMS. And it's thought that about 30 to 40% of women have at least one symptom that really bothers them. Thank God, not so many have the real severe form of premenstrual syndrome, which is called premenstrual dysphoric disorder. So that's about 3 to 8% of women. Women always ask, so why do I have this? Because if you check their hormones, they look fine. So the question is, what's going on within their bodies that suddenly they always have these kind of problems during the second part of the cycle? And the hypothesis is that they have a brain that is very sensitive to the fluctuations of the hormones of the ovary. And that due to this very sensitive brain, they have not only like mood disorders, but all kind of other symptoms. And then it's also understandable how the strategy is to reduce those symptoms. So you can either make your brain more resistant, so that it's not so sensitive for the hormonal fluctuations anymore, or you just get rid of the hormonal fluctuations, and then your brain is also happy. But to this we will come later. So now I would like to show you what we were thinking about how to deal with women with PMS a couple of years ago. It was 2 years ago when we met in Switzerland with different disciplines like psychiatrists, psychologists, and gynecological endocrinologists to be sure what we can offer from different perspectives. And before we go into detail about what we can offer to these women, just to start with the definitions. So also a couple of years ago, there was a consensus meeting where it was differentiated between core premenstrual disorder, so that's the PMD, that's what we classically define as PMS. So symptoms have to occur in ovulatory cycles. Symptoms are not specified, so you do not have to have depression. It doesn't matter what kind of symptom you have, but it must appear during the luteal phase, and it must be absent during the follicular phase. And the symptoms must have a big impact on your daily life, meaning like maybe you're fighting with your partner every time when you're in the luteal phase, or you are staying at home, or you do not socialize anymore, or you do not go to school or to work. So it's not about only of having a little bit of breast symptoms, for example, but it really has to have an impact of your daily life. So that's the core premenstrual disorder. And then we also have variants, and the most important variant is the premenstrual exacerbation of another disease. So that's, for example, if I have a depression, then I'm depressed during the whole cycle, but the depression is even worse before the menstruation starts. So this means I have a disease, but this disease is modulated by the menstrual cycle and is worse after ovulation and before menstruation. Usually when we talk about PMS or PMD, there are tons of different symptoms that might occur. And as I said, it's not necessary to have all of them. It's not necessary to have a certain amount of number. So one symptom is enough. And this might be just a mental symptom. That might be just a change of behavior. So it does not have to be a certain type of symptom. The only thing which is necessary is that it disappears when the menstruation starts. And as I've already learned, breast pain is a very important issue here. And we have like cyclical breast pain. That's the majority of women that report breast pain. And that's usually occurring during the second part of the cycle. But of course, there's also a portion of women that have non-cyclical breast pain. And this can be due to breast disease, but that can be also due to certain medication or other diseases. So the PMS or PMD can be experienced in different ways. So there are women that say, for example, my mood is bad only like 2 or 3 days before the menstruation starts. But there can also be women that say, the moment I have my ovulation, I'm really bad until the menstruation. And it still actually takes a couple of days when the period has already started until I'm really free of any symptoms. So the women are not having the same time or the same duration of symptoms during one menstrual cycle. Before we start or recommend any kind of treatment, as always, we have to take the personal and the family history. It's important to know how is your cycle, what have you already tried to reduce the symptoms. And if there's really a mood impairment, it's important to ask, have you ever thought about committing suicide? That's something our psychiatrist was very focused on, that also as gynecologists we are not afraid to ask this question, but she says you really have to ask her, because the moment she says yes, it's maybe the time point to involve the psychiatrist and not to keep it just to gynecologists. Then, of course, it's important to ask how long the patient already has this kind of symptoms, and if she's planning to be mother in the near future, because then obviously you are choosing other treatment options. So the diagnostic is actually quite easy, so you do not have to do a lot. Most importantly, it's important to document the symptom severity and the kind of symptoms a woman experiences, and we only need lab analysis to exclude other diseases. So we are not really expecting any surprises here with if someone suffers from PMS, but it's more about being sure it's not a thyroid disorder, it's not hyperprolactinemia, for example. So that's why those kind of lab assessments is indicated. And then that's already it for diagnostics, and then we can start about thinking what we can offer. And we have a lot of different things to offer, which is good, of course. So we will find something for every woman. So we have something which more belongs to the psychiatrists or the psychologists, or maybe you also know how to do it. Unfortunately, I have never done a training in cognitive behavioral therapy, so that would be something where I have to send a patient to one of my colleagues. Then we have micronutrients, we have the herbal therapy, we have hormones, We have what I think is very interesting, diuretics, and then, of course, surgery, but thank God that was never necessary. So I'm always a friend of conservative treatment. So surgery is only if nothing else helped. But I think we always will find something before we need surgery. So alternative therapy, that's just a selection. Of course, there are much more options that you can find in the literature. But still, I reduced myself, if you want, to a number of products or a number of ingredients, and I often combine them. So if for micronutrients, for example, I like to combine calcium with vitamin B6 and magnesium, and usually I give like 1,000 milligram calcium per day, vitamin B6 80 milligram per day, and magnesium 200 milligram. And that's just, if you want, level of evidence 5, because that's what I found in the literature. And then I thought, okay, I do not want to start with first magnesium, then calcium, and then vitamin B6. So I have my own little cocktail, which I prescribe. And usually I prescribe this little cocktail of micronutrients together with chasteberry. So I use calcium, magnesium, vitamin B6 in combination with Prefemin, and I give it in a continuous way. So every day one cocktail, and I see the woman back after 3 months, and I ask her to write down all her symptoms so that I can see if the duration of symptoms decreases and if also the intensity of symptoms decreases. Let's focus on chasteberry a little bit more. So again, you can see how this herb looks like, and it has been used for premenstrual syndrome treatment for a couple of years, and it has also been compared to other treatment options. So how does it work? That's always an important question if we want to try a new medication. And the idea is that chasteberry binds to the dopamine receptors in our brain. So it's again a herb that has an impact on our neurotransmitters, just like black cohosh before, but now we have other neurotransmitters that are affected. So the idea is that with chasteberry, the dopamine receptors are activated, that in turn the prolactin secretion is decreased. So it's like a prolactin inhibitor, if you want, or a prolactin secreting hormone inhibitor. And of course there are also other kind of actions that have been described, but the mode of action with dopamine receptors and prolactin is the most accepted one. Then, as before with the black cohosh preparation, we have the same situation here with chasteberry. So, and as you all know, there are different chasteberry preparations on the market, but the Prefemin is the only chasteberry product which is approved as well-established use. So that's important for all herbal products if they are approved as well-established use or traditional use, because the level of evidence for effectiveness and tolerability is better if a product is approved as well-established use. But that's a lot of regulation theory. Let's have a look at symptoms. So first of all, in this study, women were treated with 20 milligram of Prefemin per day, And at the beginning, the women were documenting their PMS symptoms for 2 cycles. And then they started treatment with Prefemin for 3 months. And then they stopped the treatment, and then they recorded their symptoms for another 3 months. And what we can see here is that after the initial baseline cycles, the symptom severity of PMS was significantly going down with Prefemin. And after stopping Prefemin, the symptom came back, but not immediately to the baseline level. So that's also important. So we see on one hand, yes, we have to continue the treatment because otherwise the symptoms will reappear. But on the other hand, we can also see there is some kind of long-lasting effect that the symptoms will not be there at the same level immediately after you stop your treatment. Then in the next study, the Prefemin was compared to placebo. Because again, you could say, well, maybe that was just a placebo effect with those women that were treated with Prefemin. And we want to know if it's really superior to a placebo. And that's the next study showing that women that were treated again for 3 cycles with 20 milligram of Prefemin, so 1 pill per day, and compared to placebo. So placebo is the gray bar and Prefemin is the green bar. And we can see here that the total score, let's look at this first, was significantly improved by Prefemin. And we can also see if we now look at single symptoms like irritability, mood alteration, headache, bloating, and also breast tenderness, that there was an improvement of all different kind of physical and mental symptoms with the help of Prefemin when compared to placebo. And then, of course, you could ask yourself, is it better to take more? You could argue the more the better, and that's the question if this is true. And this was the goal of the third study here. So in this study, women were treated again for 3 months with either placebo, that's the gray bar, or with a tiny dosage of chasteberry, so that's this light green bar. They received 8 milligram per day, or 20 milligram per day, or 30 milligram per day. And as you can see here, the regular or the approved dosage with 20 milligram was significantly superior to placebo and was significantly superior to the 8 milligram, but there was no significant difference between placebo and 8 milligram of chasteberry. So dosage matters, but it's not the higher the better, because you can see here 20 milligram and 30 milligram, this difference was not significantly different. And again, if we have a look at single symptoms like irritability, mood alteration, headache, bloating, and breast fullness, then again we can see that with 20 and 30 milligram we have a significant improvement for every single symptom, but we do not see a huge impact of, it's almost not readable, we do not have a big impact with only 8 milligram per day. And what's also very interesting in these kind of studies is that some of these women also were using the contraceptive pill. And that's important because some women are taking contraceptive pill to get rid of their PMS symptoms. And they also improved with the addition of Prefemin. So this means even if because a woman wants to have contraception at the same time, and you think, okay, let's start with a contraceptive pill, and the woman says, well, it's a little bit better, but it's not the way I want to have it, then you could still put some Prefemin on top of it, and you will have a same beneficial effect as you have it if you are not taking the contraceptive pill. I think that's that's still an interesting part, that you can combine the two treatment strategies. If we have a closer look at breast again, we have different options we can treat women with. We can just give them analgesics, but if this is not efficient, or for some reason the woman doesn't want to take it, then we also have the option to give chasteberry, as you've just seen in the study. So that's a successful strategy for women who are suffering from any kind of breast pain. If we have again a look at women who are using different kind of Prefemin dosages. So it's the same study as before. We have the placebo here. We have the 8 milligram per day here, 20 milligram per day, 30 milligram per day. We can see that the number of responders is not significantly different between 20 and 30 milligram. If a woman is being a responder is defined. So this means that I must have an improvement of at least 50% of my symptoms. So if it's only like a little bit better, that's not enough, and then I'm not a responder. I'm only a responder if my symptoms have decreased by at least 50%. And we see that the numbers of responders is not different between 20 and 80 milligram, but it's a huge difference between 8 milligram and 20 milligram. If we ask women, is there anything you do not like about this treatment? There are some adverse events that have been reported, like headache, acne, and also gastrointestinal symptoms, but usually they are not very severe, but more modest or just mild symptoms. Another indication or option for chasteberry or Prefemin is not only PMS, but it's also cycle dysregulation. And before we go into detail about this symptom, of course, it's worth to think about, okay, what kind of cycle irregularities can I have? And since a couple of years, we have a new classification. Also, I must admit, we still like to use the words we learned at medical school, and it's not so easy to really transform what we learned into the new FIGO classification. So, but for the FIGO classification, or if we use the FIGO classification, that's like the scheme we can use to classify what kind of cycle irregularity a woman has. So we have a look at frequency, duration, regularity, and blood volume. And then we can make a cross here to make it very easy. And everything which is orange here is like abnormal. So we can see quite easily if there's anything without or not within the normal range. Then, of course, it's also possible to have intermenstrual bleeding. So we can also make crosses here if this is intermenstrual bleeding, which is absolutely not predictable, or if it always occurs at the same time of the menstrual cycle. So this is helping us to define what kind of cycle irregularity the woman has. And then, of course, we would like to know why she does have this kind of cycle irregularity. And there's also another FIGO classification, and this is, has the short or abbreviation PALM-COIN. So the abbreviation PALM stands for structural disorders, and we can diagnose them with imaging techniques or histology. And the COIN components are standing for non-structural disorders. And now, of course, you would like to know what kind of structural and non-structural disorders I'm talking about. And these are the words or the causes for having menstrual disorders. So the structural disorders are polyps, adenomyosis, fibroma, or of course malignancies. This is what we can find out by histology or by imaging techniques. And the other ones like coagulation disorders, ovulation disorders, endometrial pathology, or also bleeding disorders that are produced by us, for example, by giving some kind of hormonal medication. This is non-structural disorders, but yes, and that's we can find it out by taking the personal history, family history, and of course by lab analysis. And so this was the classification for why I have a bleeding irregularity. And then of course it's important, is the bleeding acute? So do I have to do something immediately? Or is it more a chronic bleeding disorder, meaning that something has changed within the menstrual cycle profile, which at least has a duration of 6 months? And it's obvious that when we are talking now about how to manage bleeding disorders with a herbal product, we are talking about chronic disorders. So of course, if a woman is sitting in front of us and she's bleeding, the idea is not to, okay, let's try a herbal product. But then we have to do something else, which is working quite fast. But if she has like a chronic condition, then it gets interesting to see what else we can offer. And maybe this can also be chasteberry, because this is another observational study that was performed in Switzerland, including women with all different kind of cycle irregularities. So we have like polymenorrhea, oligomenorrhea, and those women received chasteberry or Prefemin for at least 3 months, and then the doctors and patients recorded if their symptoms or the bleeding disorder disappeared. And as we can see here, the green bars are showing that there was an improvement of the cycle irregularity after 3 months of treatment. Obviously, there are different reasons for having a bleeding disorder in these patients. So they do not have all, let's say, PCOS, or they do not have all fibroma. So it's a mixture of everything. And but that's probably also the situation we mostly have in our consultations. Then in the next, let's have a look here. No. Okay. So this was everything about PMS treatment with chasteberry, and not only PMS but also bleeding irregularities if the bleeding is chronically. And now we would like to have a look at what else can we offer if someone has PMS. So, and here we have antidepressants. And usually if you have a look at international guidelines, the #1 treatment is usually antidepressants. And this is probably because the study, or most studies, have been performed with using antidepressants. But a lot of women are actually afraid of starting antidepressants, and they say, well, I'm not depressed, I just have PMS, so why do you want me to take an antidepressant? But as I've said, there are a lot of studies that have shown effectiveness for SSRI and also for SNRI. And what's very interesting is that it's also working if you only use it during the luteal phase. So it's not absolutely necessary to take it on an everyday basis, but you can tell a woman you can start with ovulation and you can stop treatment on the first day of your menstruation, and only if this is, for example, not sufficient enough, then you can also take it on an everyday basis. But what was very important for the psychiatrist in our consensus group was that we just do not prescribe antidepressants to everyone, because it's quite possible that a woman does not have only PMS in a classical way, but maybe she has like this PMD variation. So maybe she has like a underlying mental disease, which is just exacerbating during the luteal phase. And then, as we are not psychiatrists, we cannot just always say, oh, let's take this or this antidepressant, but it's really necessary then also to ask the psychiatrists what they think. And our psychiatrist told me, although this is on the list of antidepressants that can be used, like tricyclic antidepressants and also anxiolytic medication, she was telling me, please do not start this on your own. That's something for me. So I'm fine if you, as a gynecologist, take like escitalopram, or if you are taking venlafaxine, but don't just prescribe everything. And if you have a woman who's already taking an antidepressant, just don't say, okay, I just give you a second antidepressant on top of it, because I've read it's working. Then it's also worth to ask the psychiatrist what she or he thinks about it. And it's also important to tell the woman that there might be some kind of side effects like nausea, insomnia, headache, diarrhea, or dizziness, and the incidence is about 15%. And sexual dysfunction, which might also be a side effect of antidepressant is about 9 to 30%. So we have to also inform women about these possible side effects if we start treatment with this. Then, if we are thinking back to why someone has PMS, and we think, okay, the brain is very sensitive to the hormonal fluctuations of the ovary, we can make the brain more resistant. So that was the idea of the antidepressants. But we can also think, okay, let's get rid of these hormonal fluctuations of the ovary. And that's the idea of taking combined oral contraceptives, and with reducing the number of hormone free days. So usually you just give it continuously, then the woman will have amenorrhea most of the times, but she will not have any breaks where the ovary restarts working again. Then we can also give GnRH analogs, but that's a more aggressive therapy because you have to give her injections and then you have to give her an add-back hormone therapy. So that's nothing to start with. And what's very interesting is the idea of giving transdermal estrogens. Because if you give high dosages of transdermal estrogens, you can suppress ovulation. And there are several studies from the 80s who have shown that a certain dosage of estrogens are suppressing the ovulation, and it's helpful against PMS. And of course, you have to give a progestin for endometrial protection. And that's something very interesting also, as you will see later on, for women during the perimenopausal transition. Another treatment option, which is very interesting, is diuretic. It's spironolactone. So, and this can be given only for the second part of the menstrual cycle. So you started with the ovulation, you stop it when the menstruation starts. And it's improving not only physical symptoms like breast tenderness or fluid retention, it also improves like mood. And that's very interesting because you think, why should a diuretic improve your mood? But as spironolactone is also an anti-androgenic agent, it probably works via this level also against the mental part of PMS. So that's also very interesting if someone has a contraindication for hormones, for example, but it's necessary to control for potassium before you start it and then after like 4 to 6 weeks again. Now, I skipped this one, and I know that's very hard to read, but you can download it from PubMed. It's free access, so it's not, you do not have to pay for it, or you do not have to be registered to the journal. And that's our final conclusion for the of the PMS consensus meeting. And we have one algorithm for women during their reproductive years and one algorithm for women during the menopausal transition. Because we thought it's important to also consider the age of a woman. Usually, if you look at international guidelines, they just put the medication in a huge list, but they do not differentiate how old the woman is. And we think it's important to also consider this aspect. So let's imagine we have a woman during their reproductive years, and she's presenting with premenstrual symptoms. Then if she has never tried anything before, then it's a good idea to try the alternative treatment first. So we can give her either Prefermin alone. We can also combine it with calcium, magnesium, or vitamin B6. And then she will document her symptoms for 3 cycles, and then we see her back. And then, depending if she improves or not, we can decide on other treatment options. So second-line treatment, if, for example, she needs also contraception and she does not have a contraindication towards oral contraceptives, we can try oral contraceptives on a continuous basis. Or if there's a contraindication or she does not need contraceptive, then we can try antidepressants. And as you've seen, we have different kind of antidepressants. We can give them in the luteal phase only, or we can give them continuously. So that's why for the antidepressant section, we have several options we can offer before we go to the third-line therapy. So if everything is not working, we still have the option with spironolactone, given only during the luteal phase, and we have the option of ovulation suppression with transdermal estrogens. Then, as a fourth-line therapy, we can suppress ovulation with GnRH analogs and add back hormone therapy. And finally, theoretically, we could do surgery. But as I've said, usually this is not necessary because we have so much else, so that usually we can find a solution. If we look now at the older women, so this is the algorithm for the perimenopausal women, and it almost looks the same. There's only one difference. So first-line treatment, again, alternative therapy with micronutrients or combined with Prefermin. And then if this is not working enough, again, if she needs contraception, we can offer contraception, but probably it's a better idea to use an oral combined contraception which contains estradiol and not ethinyl estradiol due to the thromboembolism risk. Then what I think is important to include here is the option of progesterone only. Because when you have a look at international guidelines, you never find progesterone alone. It's everything else but not progesterone. And the reason why it's not officially recommended anymore is because there's one Cochrane analysis showing that progesterone alone was not superior to placebo in PMS patients, and that's why it is excluded from all guidelines. But as we all know, during the perimenopausal transition, the hormone which fluctuates first or the most at the beginning is progesterone. So it's quite a good idea, not only for cycle regulation, but also for PMS treatment, to try progesterone during the second part of the menstrual cycle. And then the rest is the same. So we can give her antidepressants, we can try spironolactone, and so on. So the only difference is here progesterone alone during the second part of the cycle. And if we decide to use a combined hormonal contraception, it's better to take an estradiol containing contraceptive and not ethinyl estradiol. So we are already coming almost to the end. So summary. Chasteberry, or as we've learned now from our studies, Prefemin is a well-characterized. The Prefemin is the only approved medication with a label well-established. It helps against PMS symptoms. And we have seen that 20 milligram is superior to 8 milligram, but 30 milligram and 20 milligram are more or less the same. So the idea is not to increase it more and more and more, but we still have to remember that taking the lowest dosage is also not the best idea. So 20 milligram has been shown to be sufficient here. And it also helps to improve cycle irregularities. Of course, we have to keep in mind when we think of the FIGO system that there are different kind of reasons for having cycle irregularities. So most likely it's not helping against everything, but we have shown from a quite heterogeneous cohort that a lot of women will have improved cycles after 3 months of treatment. And now we come to our 3 patients. You remember the first one, 25-year-old. She has mood swings, she has bloating, she has mastalgia. And the question is, what can we do? So, first option, if she has never tried anything before, we can combine Prefemin with, we can either give it alone, we can combine it with micronutrients, magnesium, calcium, and vitamin B6. As I said, that's my personal cocktail. So Prefemin is level of evidence 1, the whole cocktail is level of evidence 5. Or we can give her combined oral contraception if contraception is needed and if she does not have a contraindication. Or, of course, we can try antidepressants during the luteal phase only or continuously. And as you can see, usually we do not need a huge dosage of antidepressants. Usually it's enough to give half a pill or 1 pill only. The second patient, that was, I know her probably now since 3, 4, 5 years. And she came to me and she already had lithium by her psychiatrist. But she was telling me that before the luteal, during the luteal phase, the lithium was not efficient enough, and she was asking me what she could do about it, and she did not want to take any hormones. So here again, we started with Prefemin and the whole cocktail. This was, in this situation, not enough. Then I was asking her psychiatrist if she could not increase the lithium dosage during the luteal phase. So that's always an option if you already have someone onto taking a pharmacotherapy, that you just adjust the dosage during the second part of the cycle. And in this case here, we tried spironolactone, and I was really impressed when she came back and told me, you know, it's so much better. And I was like, oh my God, really? Yeah. So I was very happy with her and with this case, that just taking spironolactone during the second part of the luteal cycle helped her so much. But in this case, it's always important to check for potassium, not only because she's taking spironolactone, but also because lithium has an impact on electrolytes. So here it's important to really work together with a psychiatrist and to check for the lab values that might be might be affected by both medications. And the last patient, that's our women during the menopausal transition. And it's not a surprise that her PMS symptoms are getting worse and worse when she is aging and going through menopause, because if you remember that PMS occurs most likely due to a very sensitive brain to hormonal fluctuations, you can expect that it's getting worse when you enter menopause, because the fluctuations are worse and worse than before. So that's a classical situation. And again, what can we do? We can again just try something from our alternative treatment options. We can also combine it with black cohosh if she also has hot flushes. We can also try micronized progesterone during the second part of the menstrual cycle. We can also offer hormonal contraception, but then it's probably better to use estradiol as the estrogen component and not so much ethinyl estradiol. And of course, we can use antidepressants during the luteal phase only or on a continuous basis.